Short duration massage at the hamstring's musculotendinous junction induces greater range of motion. School of Human Kinetics and Recreation, Memorial University, Newfoundland, St. John's, Canada. Institute of Teaching of Physical Education, Cordoba, Argentina, and Faculty of Health Science, University of Catamarca, Argentina. Introduction. Among medical, health, and athletic professionals, flexibility and aerobic conditioning and strength training are considered important components of an exercise program. Van den Tillaar indicated that sufficient range of motion, ROM, caused by poor muscle flexibility may be a cause of muscle strain and increased risk of injury. To enhance ROM from a healthy perspective, it is typically necessary to engage in systematic stretching over a period of time. In many sports, such as squash, tennis, wrestling, and goaltending and ice hockey, among others, it is necessary to achieve a greater ROM to ensure athletic success. The recent literature has many examples of static stretching increases ROM. However, it has also been reported to impair subsequent force, jump height, sprint time, muscle activation, reaction and movement time, and balance. Compared with common static stretching techniques, at least one study used massage has been shown to increase ROM without exhibiting detrimental effects on force production. In addition, 15 and 30 minutes of massage respectively did not adversely affect 30-meter sprint running time. Barlow et al. Reported no effects of 15-minute of hamstring massage on the electromyography EMG activity associated with a sub-maximal voluntary contraction, other than a single study using 15 minutes of petrissage massage that impaired muscle strength. A few studies documented the effects of massage on athletic performance generally indicated minimal adverse effects. Hence, if massage can increase ROM, it may be an alternative or complement to static stretching. During the warm-up, cool-down, and specialized flexibility training. However, not all massage studies report increased ROM. 2 studies using 15 minutes of hamstring massage indicated no change in ROM with adolescent soccer players and active adults. Conversely, Hopper et al. In 2 studies observed increased hamstring flexibility with 8 minutes of dynamic soft tissue mobilization and classical massage. Therefore, the effectiveness of total massage for increasing ROM is still debatable. The present study introduces a novel massage technique to increase ROM. Previous massage studies applied massage on the muscle belly, whereas the present study focused massage on the musculotendinous junction. Secondly, the previous study cited research regarding massage effects on ROM has implemented a 60 through 30 minutes of massage, whereas the massage duration in the present study was 10 and 30 seconds. This duration would be more conducive to the time limitations of most warm-ups and cooldowns. Flexibility, enhancing protocols that save time without compromising ROM could be advantageous in a variety of athletes and the general population that often list time constraints as a limitation to exercise and fitness. Athletes are seeking to achieve greater ROM, or individuals who have difficulty achieving a functional ROM with traditional static stretching could benefit from a short duration, simple technique that can be used in conjunction with static stretching or alone to enhance ROM. Musculotendinous massage before static stretching has been used to successfully in clinical settings, personal correspondence, Professor Di Santo, Argentina, with both athletic and clinical populations. However, there have been no control groups with which to validate these clinical findings. Also, there are no studies attempting to identify possible mechanisms underlying their action. Although contentious, massaging the musculotendinous junction could theoretically activate the inhibitory action of the Golgi tendon organ, GTO, or lead to a presynaptic inhibition of the IA sensor fibers in the spindles of the activated muscle. Hence, this study will examine both EMG activity and passive muscle tendon to examine if possible to detect if massage induced changes in ROM are because of changes in reflex-induced muscle action or the muscle stiffness or compliance. The objective of the study was to investigate the effects of short-duration, 10 and 30-second musculotendinous massage and hip flexor ROM. Passive hamstring tension and EMG activity is both hypothesized that with short duration massage concentrated on the musculotendinous junction of the hamstrings, there will be an increase in ROM with no associated increase in passive leg tension or EMG activity. Methods. Experimental approach to the problem. To validate techniques to improve ROM presently being used by professionals in the field, 2 different durations of musculotendinous friction massage were compared to a control group to ascertain if claims of clinical success were valid or could be ascribed to a placebo effect. The research design was a classical experimental design with 1 control and 2 experimental groups. Subjects attended 3 sessions on separate days, control, 10, and 30-second massage, within a 1-week period. Counterbalancing was used with the order of intervention techniques to reduce practice or boredom effects. Each session consisted of a 5-minute active aerobic cycle warm-up followed by a 5-minute rest period. After the post-warm-up rest period, 3 pretest measures of hip flexion, ROM, hamstrings, EMG, and passive muscle tension were performed. After another 5-minute rest period, 1 of the 3 intervention techniques was applied: control, 10, or 30 seconds of musculotendinous friction massage. 3 post-test measures, same as pre-test, were taken starting at 5 and 10 seconds after the intervention. Hip flexion, ROM, hamstrings, passive tension, and EMG were the variables recorded and analyzed during the 3 pre-season pre- and post-test measures. The 3 post measures were separated by 5 seconds of rest, during which the leg was returned to rest on the table. The mean of the 3 pre-test and post-test measures was used for analysis, figure 1. Subjects. The participants were 10 women ranging in age from 21 to 36 years with a mean age of 24.3 plus or minus 5.9 years. The participants had mean weight and height of 73.3 plus or minus 12.5 kg and 172 plus 3.3 plus or minus 4.3 centimeters respectively. All participants were healthy and recreationally active. None of the participants were on a consistent training program. They were all former high school or university level former athletes who presently participated in a variety of recreational activities: aerobic fitness on treadmills, rowing, and cycle ergometers, basketball, volleyball, at least twice a week. Because testing was performed in January and February, most extracurricular activities were indoors. None of the participants had injuries that limited ROM at the hip or knee joint. Participants were recruited through convenience, visit undergraduate courses, and ask for volunteers, and snowball sampling, participants contacting other individuals that they thought would be interested in the study. Because only a few men volunteered for the study, women were selected to reduce the possibility of high variability associated with gender differences in ROM and muscle tension. There was an insufficient number of male volunteers to parcel gender as a separate variable. All participants provided written consent to participate in the study. The study was approved by the Memorial University of Newfoundland Human Investigation Committee. Measurement protocols. Hip flexion range of motion. Static flexibility is defined as the ROM that is available to a joint or series of joints. Hip flexion ROM in this study was measured directly using a manual goniometer and the passive straight leg raise technique. The goniometer was accurate to 1 degree. This technique involved placing the subject in a supine position and attaching a custom plastic knee brace to ensure the knee remained in full extension. The subject's leg was passively raised to induce flexion at the hip with minimal hip rotation until the subjects verbally indicated the point of discomfort had been reached. The point of discomfort was described to the participants as the point in which they first feel the onset of uncomfortable tension or stretch in the hamstrings. During the leg raise, no movement of the opposite leg was ensured. The participants were also instructed to remain relaxed and to avoid any voluntary contractions. The angle measured was the angle between the long axis of the thigh and the long axis of the torso, using the greater trochanter as the axis of rotation. Range of motion data was calculated by subtracting the post-test values from the pre-test values for each condition. 3 trials were performed with the mean used for analysis. Hamstrings electromyography activity. Electromyography activity was monitored in an effort to ascertain whether the interventions provoked reflex modulated changes in muscle EMG activity. Unlike a strong muscular contraction, the EMG activity from a passive stretch was expected to provide a low signal-to-noise ratio. Thus, a pretest was used for all interventions in addition to the control condition in an attempt to decrease the variability that might appear when EMG activity is recorded and compared from separate sessions. Surface EMG recordings electrodes AG and AGCL disc shaped 10 mm in diameter were placed on the hamstrings semimembranosus at the midpoint between the ischial tuberosity and the posterior aspect of the lateral epicondyle of the femur. Skin preparations included shaving the area of interest, followed by removal of dead epithelial cells with a piece of sandpaper and cleansing with isopropyl rubbing alcohol 70%. 3 electrodes, Kendall, Medi, Trace 130, electrocardiography, conductive adhesive electrodes were used to determine the EMG output. 2 electrodes were placed back to back, approximately 2 centimeter electrode to the electrode distance over the marked midpoints on the posterior aspect of the thigh. A ground electrode was placed on the proximal head of the fibula. Electromyography activity was sampled at 2000 Hz with a Blackman -61 dB bandpass filter between 10 and 500 Hz amplified bipolar differential amplifier input impedance around 2. Common mode rejection ratio greater than 110 dB minutes, 50/60 Hz. Gain times 1000, noise divided by a greater than 5, and analog to digitally converted 12-bit Bioptic Systems Incorporated, Holliston, Massachusetts, USA, DA100 and analog digital AD converter, MP100WSW, Hillston, Massachusetts, USA, and stored on a personal computer for further analysis. The filtered signals were rectified and integrated over a 3-second between the 1 and 4-second mark of the 5-second stretch during maximum ROM. Acknowledged. 3. Biopic Systems Incorporated. Hamstrings, passive stretch. Passive tension of muscles described as the tension provided by the muscles and muscle membranes when the muscles are not activated. Changes in passive muscle tension associated with massage would illustrate if alterations in the mechanical properties, compliance of the musculotendinous unit have occurred with the interventions. The passive tendon of the hamstrings was indirectly measured using the passive torque force created at the posterior of the knee at the point of discomfort. The passive torque force was measured using a handheld dynamometer, Lafayette Manual Muscle Test Systems Model 01163. The handheld dynamometer operates at a range between 0 and 22.6 kilograms and is accurate to plus or minus 1 degree over the full scale. The resolution is 0.1 kilogram. The device was placed on the popliteal space perpendicular to the long axis of the leg with the knee fully extended and held for 5 seconds. The maximum force, kgs, was measured and recorded. 3 trials were performed with the mean value used for analysis. Pilot muscle tension validity study. To ensure that the handheld dynamometer, manual strain gauge, was sensitive to changes in tension associated with increase in ROM, the subjects participated in a prior pilot stretch study with no massage intervention. Subject's extended leg, same preparation as previously described, was passively placed in a flexed hip position while the individuals lay supine on a mat. Muscle tension force measures were taken using the same aforementioned protocol, except for the leg was placed in 5 position angles. The 5 extended leg positions were randomly allocated, consisting of a 10 degree from perpendicular to the floor, 80 degrees from floor to, or 100 from the torso, and labeled as 100 degrees. B. 15 degrees from the perpendicular to the floor and labeled as 105 degrees from the torso. 110, 115, and 120 from the torso, or 60 from the perpendicular to the floor. The stretched position was held for 5 seconds, and a 1-minute rest was allocated between measures. Identical to the aforementioned description of passive muscle tension, the device was placed in the popliteal space perpendicular to the long axis of the leg and held for 5 seconds. The maximum force, kg, was measured and recorded. 3 trials were performed with the mean value used for analysis. Intervention protocol. Each subject completed the 3 protocols within a 1-week period. Because all women were on birth control, radical fluctuations in the hormonal responses affecting flexibility would not have been expected. A 5-minute active warm-up was followed by a 5-minute rest period. Subsequent to the 5-minute post-warm-up rest period, 3 pretest measures were performed, followed by another 5-minute rest period. Interventions included the control protocol that involved no massage, where the subject remained in the supine position for 30 seconds. Post-intervention measures commenced 5 to 10 seconds after each intervention or control condition. For the 10 and 30-second massage conditions, friction massage was applied at the musculotendinous junction of the distal portion of the hamstrings. Friction massage is characterized as an accurately delivered, penetrating pressure applied through the fingertips. This pressure was applied in small circular motions with deep pressure by the same investigator for each subject. The subject's knee was extended and the subject was in a supine position. The investigator grasped the subject's thigh with both hands, thumbs on the quadricep, and applied friction pressure in circular motion with the fingers at a pace of approximately 1 RPM to the musculotendinous junction of the hamstrings. This duration and type of massage have been reported to be successfully used in certain clinical applications. Personal correspondence with Professor Di Santo, however, without control conditions, the claims of clinical success might be attributed to a placebo effect. The first of 3 hip flexion ROM measurements were conducted immediately within 5 to 10 seconds after a massage technique, with 5 seconds between the ROM measurements, 5 seconds to place the leg at its greatest ROM, and 5 seconds for the ROM tension and EMG measures for the entire testing protocol was completed within 1 minute after the massage treatment. Statistical analysis. Data were analyzed using SPSS version 16.0. Descriptive statistics, mean plus or minus SD, were used to summarize the data. Kolmogorov-Smirnov normality tests were applied to all the data to ensure normality. The Mochlis test was conducted to determine sphericity of the data. With no violations of normality or sphericity, no adjustments were made. Change in hip flexion, ROM, passive tension, and EMG were assessed separately using a 2-way 3x2 repeated measures analysis of variance, ANOVA, with the factors being massage conditions, control, 10 seconds, and 30-second massage, and time pre- and post-test. The pilot muscle tendon tension validity study employed repeated measures, 1-way ANOVA, to compare the 5 position angles. A post hoc pairwise comparison with no adjustments was used to compare between group differences. A level of significance was set at p is less than or equal to 0.05. Reliability was analyzed by comparing the pretest measures of the 3 interventions, pretest of control, 10 and 30-second massage, with the interclass correlation coefficient, ICC, with a 95% confidence interval, SPSS version 16.0 point. When comparing the changes in ROM for the 10 and 30-second massage to the control conditions, the statistical power at an alpha level of 0.05 was calculated to be 64.3 and 95.3% respectively. The statistical power for the EMG data with alpha level of 0.05 was 97.1, 57.6, and 56.4% for the pre- and post-testing of the control, 10 and 30-second massage data, respectively. Results. The data for change in hip flexion, ROM, passive tension, and EMG activity did not show significant skewness or kurtosis for any condition. A Kolmogorov-Smirnov normality test was conducted indicating that the data were normal for all conditions and measures. Muchli's test was conducted on the data and sphericity was not violated. The ICC test for reliability revealed correlation coefficients of 0.95 for ROM and 0.66 for EMG activity and 0.74 for passive muscle tension. There were no significant changes in passive tension or EMG activity across conditions or time. Pilot muscle tension validity protocol. With no massage intervention, the pilot tension study exhibited significantly, P is equal to 0.908, greater muscle tension at the greatest ROM, 100 degrees, as compared to 115 and 120 degrees positions, figure 3. The 100 degree position demonstrated 20 21.1 and 21.3% greater passive muscle tension than the 115 and 120 degrees position, respectively. Range of motion. There was a main effect for conditions pre and post test measures combined, with the 30-second massage providing a significantly greater hip angle ROM than the control condition. P is less than 0.05, ES equals 0.73. There was no significant difference between the other conditions, figure 2. There was also a main effect for time, conditions combined, with the post-massage hip angle being 7.0% significantly greater, pre-massage 81.8 plus or minus 17.3 degrees versus post-massage 87.6 plus or minus 17 degrees. Then the pre-massage hip angle, P is less than 0.01, ES equals 0.716. Significant interactions occurred with no pre-post changes in ROM in the control group, contrasting with an increased ROM, P is less than 0.05, in the post-test of 5.8 and 11.3%. For the 10-second, ES equals 2.3, and 30-second, ES equals 2.3 massage conditions, respectively, figure 4. Discussion. The most important finding of the current study was the significant increases in hip flexion ROM with only 10 seconds, 5.9%, and 30 seconds, 7.2% of musculotendinous massage. Previous studies have reported conflicting results, with a single bout of 15 minutes of massage eliciting no significant changes in ROM with adolescent soccer players and active adults, contrasting with 3 other studies reporting increased hamstring flexibility with 8 minutes and 3 minutes of massage. This main finding of the present study indicates that a brief duration massage at the musculotendinous junction can provide an increase in hamstring flexibility, hip flexion ROM, that is comparable to other common methods of stretch, albeit with a shorter time commitment. These findings are comparable or exceed the effects of acute bouts of static stretching. Various static stretching studies have shown increased hamstring flexibility of 10.2% with 30 seconds, 6% with 270 seconds, 3.6% with 90 seconds, and approximately 2% with 45 seconds of static stretching. Similar to some proprioceptive neuromuscular facilitation (PNF) stretching studies that have demonstrated 7.8% increases in hip ROM after 5 minutes of PNF stretching. The present massage results also exceed the 0.3% increase in leg extensor ROM with 4 different PNF exercises reported by Merrick et al. Hence, short duration exercises reported by Merrick et al. Hence, short duration massage at the musculotendinous junction without additional stretching can provide ROM improvements similar to other stretching techniques. Although the massage technique was delivered without additional stretching, further studies should examine whether the combination of stretching and massage provides cumulative increases in ROM. This combination of musculotendinous massage following immediately with static stretching has been used by certain clinicians, Professor DeSanto, for example, to augment the ROM achieved by static stretching alone in both athletic and clinical populations. Now that this study has verified with the control condition the effectiveness of musculotendinous junction massage for increasing ROM, further studies using control groups can determine both the cumulative effects of massage and static stretching and the persistence duration of the technique. The significant increase in hip flexion ROM in the present study did not elicit increase in passive leg tension. The pilot muscle tension validity study demonstrated that without any interventions, hamstrings passive tension increased 21.3% over a 20-degree hip flexion ROM. Thus, the lack of increases in hamstring passive tension with a massage-induced around 6 to 7% increase in ROM could suggest an increased muscle compliance or decreased muscle stiffness because of the massage intervention. Increases in muscle tendon compliance may be achieved with massage by mobilizing and elongating shortened and adhering connective tissue. Another possibility is that the massage caused increases in skin and muscle temperatures, leading to augmented blood flow to the area. Although Drust et al. Reported increased skin and muscle temperatures with massage, their massage duration was minimum of 5 minutes compared with a maximum of 30 seconds in the present study. Thus, it would seem more likely that the focused massage upon the musculotendinous junction resulted in a mechanically induced decrease in muscle tendon stiffness. Electromyography activity did not increase with the increased ROM in the present study. It has been suggested by some authors that the massaging the muscle would produce a autogenic inhibition of the target muscle by activating the GTO, or lead to a presynaptic inhibition of the 1A sensor fibers from the spindles of the activated muscle. Taking into consideration that an increased ROM should place the muscle spindles under greater stress, because an elongated or stretched muscle, an increase in EMG activity because of spindle-induced stretching reflex might be expected. However, Chalmers elucidates that the amount of reflex-induced EMG activity associated with the maximum ROM is very low or minimal and may not be physiological meaningful. Similarly, Magnuson et al. Observed a stretch-induced EMG signal to only 1% of the MVC EMG. Because in their study, the EMG activity did not change in conjunction with force loss after 90 seconds of stretch. They also concluded that the EMG associated with the stretch reflex did not contribute significantly to the stretch-induced force resistance. In the present study, 8 of 10 subjects experienced a decreased EMG activity after the 30-second massage condition, down 12.1%. However, the variability of the data obviated any statistical significance. If there are neurophysiological inhibitory responses present similar to the stretch-induced depression of the Hoffman H reflex, the signal-to-noise ratio of the global surface EMG signal may not be sensitive enough to illustrate these massage-induced effects. A further possibility has been suggested that the massage may increase ROM by reducing the muscle's ability to detect pain and therefore allowing a greater ROM before experiencing discomfort. This theory refers to a local lateral inhibition of the spinal cord. The inhibition may be caused by tactile information stimulating larger, rapidly conducting nerve fibers that could compete with and partially block smaller, slower nerve fibers that detect pain. One study by Mitchell et al. Found that after PNF, subjects' stretch tolerance was greater than after a slow stretch. These findings are similar to those of Magnuson et al., who also reported that increased flexibility may be attributed to altered stretch perception or increased stretch tolerance. Given these results, musculotendinous junction massage may also be a viable alternative in rehabilitation situations to help restore ROM. Patients with extremely limited ROM or those who experience excessive pain during passive or PNF stretching may benefit from musculotendinous junction massage to regain flexibility. Massage may also benefit rehabilitation patients through psychophysiological mechanisms such as lower anxiety and increased relaxation. A limitation to the study was that only one bout of massage was used and only one post-intervention measure was taken. Therefore, the duration of the musculotendinous massage effect was not determined. Secondly, the massage technique was used in isolation and not in conjunction with other stretching activities to determine if there was an additive effect on musculotendinous massage to other stretching techniques. It would also be interesting to investigate the effectiveness of this massage technique when used in long-term stretching programs. In conclusion, the present study demonstrated that using one bout of short-duration 10 to 30-second massage at the musculotendinous junction can result in increased ROM without an increase in passive stress, muscle tension, or EMG activity. It was also demonstrated that 30 seconds of musculotendinous massage provided greater overall ROM benefits than 10 seconds. This increased ROM might be attributed to a massage-induced decrease in muscle tendon stiffness. A neurophysiological mechanism might involve a modified stretch perception or increased stretch tolerance because of competing afferent signals. Further research is needed to identify the mechanisms of musculotendinous massage, but it appears that it may be a useful technique for increasing acute ROM for athletes, the general fitness, or health-concerned individuals and rehabilitation patients. The practical applications: athletes, coaches, and fitness enthusiasts can apply massage at the musculotendinous junction for at least 10 seconds and expect a significant increase in static ROM. 30 seconds of musculotendinous massage should provide an even greater improvement in flexibility. Clinicians tend to use the musculotendinous massage before static stretching to attain greater ROM. Individuals such as athletes who wish to maximize their flexibility may consider adding this short duration massage technique to their stretching routine to augment increases in ROM. The research tends to indicate a lack of impairment in subsequent performance with massage. Thus, short duration musculotendinous massage may be beneficial in increasing ROM before or after a training routine or athletic event without adding an additional substantial time involvement. Acknowledgements. This study was supported in part by a research grant from the Natural Science and Engineering Research Council of Canada.